All right, I think we'll get started. Welcome everyone to this week's Medical Grand Rounds, citywide Grand Rounds of the Department of Medicine. I'm stepping in and filling for Dr. Madeline Verhofstadt, who's the Chief of Medicine here at St. Joe's. She's unfortunately unable to attend today's rounds. For those of you who don't know me, I'm Jason Chung. I'm one of the general internists here at St. Joe's. I'm currently the head of service, and I will be hosting today's rounds. So to begin, I'd like to start off with the land acknowledgement. So we acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So for today's rounds, it brings me great pleasure to introduce you all to a good colleague, friend, and fellow member within the Division of General Internal Medicine, Dr. Katherine Steckham. For those of you who don't know Katherine, Dr. Steckham is a graduate of our core internal medicine program here at McMaster. She previously completed her undergraduate MD training at the University of Toronto. Following her residency training, she went on to specialize or subspecialize in OB medicine, having completed 2 fellowships, both in University of Calgary as well as at McMaster. She then completed some time with us as a clinical scholar before joining the faculty as assistant professor within the Department of Medicine back in July of 2025. Currently, she's also in the midst of completing a Master's of Health Management through the DeGroote School of Business. So without further ado, let Katherine take it away.
Thank you, Jason, for the introduction. So today, as you guys can see, I'll be chatting about preeclampsia. And I think the main thing that I really want to highlight is that this is a disease for every subspecialty to be aware of and to know how to manage because of its multi-system involvement and often our interdisciplinary care of these patients. So I do not have any conflicts of interest to disclose. So why is this important and what's the clinical importance of it? So there was a population-based study spanning from 2012 to 2021 that was published within CMAJ that showed it included about 2.8 million hospital admissions, and they were showing a rise in the rate of hypertensive disorders of pregnancy within that period of time. So we would see an actual rise from 6 to 8.5%, and this is the term that encompasses different conditions such as gestational hypertension, preeclampsia, and HELP. So why is this happening? We know that risk factors for hypertensive disorders of pregnancy are also increasing. So this would include things like obesity, prediabetes, or diabetes, as well as individuals becoming pregnant at advanced maternal ages. And then our detection rate of hypertensive disorders of pregnancy and our increased knowledge is also contributing to the changes that we're seeing. So for this presentation, the learning objectives are to be able to describe the pathophysiology of preeclampsia, recognize a diverse clinical presentation and multi-system involvement, formulate a multidisciplinary approach, and also summarize where we're headed within preeclampsia research and our understanding of this disease. There are 2 main guidelines to be aware of, but I'll really focus on the sort of Canadian clinical practice guideline by the Society of Obstetrics and Gynecology of Canada that was published in 2022. There is an international guideline that contains a lot of the similar information with only minor variations. There is a case that I would like to highlight throughout the presentation of a case of severe preeclampsia. So I just want to introduce that, and then we'll sort of be coming back to that as we talk through the multi-system involvement. So this was a 27-year-old in their first pregnancy who presented to hospital at 24 and 3 weeks gestation. with severe hypertension, so blood pressure initially of 190 over 118. Symptoms included headache, nausea, vomiting, right upper quadrant pain, as well as edema. And then in order to confirm end organ involvement in the context of preeclampsia, labs then showed mildly reduced platelets of 136 and elevated creatinine of 77, as we typically see more values of around 40 to 50 in the context of pregnancy. Proteinuria, mildly elevated ALT, and it is this, the history, symptoms, and labs that actually would then lead to a diagnosis of preeclampsia in this patient. Unfortunately, there was quite a significant progression for this patient over a short period of time, within hours. Their blood pressure was stabilized with some short-acting agents, so Adalat IR as well as hydralazine, but the laboratory worsening was evident, with platelets dropping to 92, creatinine increasing to 84, and the aminotransferases increasing into the 100 range. And this was all within hours pre-delivery. And then a code blue was called for an eclamptic seizure. The patient was loaded with magnesium sulfate, underwent an emergency C-section, and there was evidence of fetal manifestations of preeclampsia, specifically IUGR, or intrauterine growth restriction. So we'll sort of come back to this case as we talk about the different organ involvement. So how do we define hypertension in pregnancy? It is different than our GIM population. It's defined by a systolic blood pressure of greater than or equal to 140, or a diastolic blood pressure of greater than or equal to 90. And you only need an average of these measurements, 2 measurements taken 15 minutes apart. So you can diagnose this in the office. And that is large in part because of the complications that we see in terms of hypertension in pregnancy, but also because our timeline of management is shortened in the context of pregnancy. Severe hypertension is defined by systolic blood pressure greater than or equal to 160 and a diastolic blood pressure greater than or equal to 110. And then apart from the actual numbers, there's also a timeline that we are aware of in terms of when is this patient actually developing hypertension. So obviously, if it's pre-pregnancy, that's chronic or pre-existing. But we also have, if someone develops hypertension early in their pregnancy, so before 20 weeks, we do think of this as more chronic or pre-existing. And I'll talk about why that is in the next slide. Whereas if it's after 20 weeks, we deem it more gestational hypertension. In terms of our blood pressure in pregnancy and what generally happens with the physiologic changes, you can see on this slide that the thick black line is a representation of blood pressure, the yellow line is our systemic vascular resistance, and then the red is the blood volume. So in terms of the blood pressure, we generally talk about having a dip down or nadir around 20 weeks gestation with a reduction in our systemic vascular resistance. And then that will gradually increase until delivery or 40 weeks gestation with increasing in our blood volume. And then after delivery, postpartum day 3 to 6 or 7, we can actually see a further rise in blood pressure due to rapid volume shifts and mobilization of interstitial fluid. And then we see a tapering off and a decrease in our blood pressure after that. Now, it looks like a pretty, extreme drop in the blood pressure within this diagram, but then this has gone on to be studied and looking at gestation-specific blood pressure ranges. And we now acknowledge that that dip or nadir may not be as much as we initially thought, and it sort of varies per person. So this study looks at the chart on the left-hand side is looking at different quartiles of blood pressure, and then on the x-axis, the gestational age. So you can see that that dip is not as extreme. The change that they identified within the systolic and diastolic blood pressure was a change of 1 millimeter of mercury. But in general, there is a trend that there is a slight decrease until around 19 or 20 weeks, and then increasing until about 40 weeks gestation. The other thing that I just want to highlight within this chart in the quartiles is that it's good to be aware of where someone is starting in terms of their blood pressure in pregnancy, because even though you might not reach the threshold for a diagnosis of hypertension, so that 140 over 90, or for initiating pharmacotherapy, someone really early in their pregnancy having a blood pressure of 130/80 is above the 90th percentile. And that is something to be aware of and to recognize that is not what we would expect for where they are in their pregnancy and their gestational age, and someone that requires more monitoring throughout in terms of their blood pressure. So, as I alluded to before, hypertensive disorders of pregnancy are common. So, it affects 10 to 20% of all pregnancies, with preeclampsia occurring in 2 to 8% worldwide. And it is associated with significant maternal and fetal morbidity and mortality, especially in the context of low resource settings. The definition of preeclampsia has been slightly modified over the years. We know that hypertension is a predominant feature, and then it used to be with proteinuria. But now the definition is saying proteinuria or one or more adverse conditions after 20 weeks. And I'll go through a table about what those adverse conditions are. For our institution here at McMaster, for defining proteinuria, we utilize the urine protein creatinine ratio. And what would be abnormal based on the units we utilize would be anything above 0.03. Now, we have identified some inconsistencies in this measurement. So sometimes we are either confirming with a urinary, the albumin creatinine ratio, which would be greater than or equal to 8 for preeclampsia diagnosis, or a 24-hour collection, which would be greater than 0.3 grams per day within the 24-hour period. Although sometimes, based on timing, we can't actually collect that. Another thing to note is that preeclampsia is not something that only happens during pregnancy. It can also happen postpartum. And we need more education on that too. The same risk factors apply for these individuals who develop postpartum preeclampsia. It often occurs within the early postpartum period, around 7 to 10 days. And these patients generally have more neurological features, so headaches and visual changes when they present to hospital. In regards to the pathophysiology, just on sort of a brief understanding of that. So normally what happens in pregnancy is that the trophoblasts, which are these cells that essentially line the blastocyst and provide nutrients to the embryo, will invade the endometrium, leading to spiral artery remodeling and obliteration of the tunica media of the myometrial spinal arteries, and allowing for basically increased blood flow to the placenta. But in preeclampsia, these trophoblasts fail to adopt that endothelial phenotype. So with the abnormal invasion, incomplete spiral artery remodeling, you get endothelial dysfunction and release of pro-inflammatory cytokines. And this leads to uteroplacental insufficiency and ischemia, which then also leads to increased angiogenic markers. And the main one that we'll be focusing on is going to be the soluble FMS like tyrosine kinase 1 or SFLT1, because this decreases levels of VEGF as well as placental growth factor. This sort of cascade of events is what leads to endothelial dysfunction in the vasculature, a vasoconstrictive state, increased oxidative stress, and microemboli, and why we see this multisystem involvement and clinical presentation. And then there's also immunologic aberrations that occur that then lead to more of a pro-inflammatory state. This is just a depiction to show you that this trophoblast invasion is something that's happening very early on in someone's pregnancy. So, in the first trimester, this is where we're identifying that individuals are going to be at higher risk of preeclampsia, and why our interventions are starting at that stage, and then the cascade of events occur thereafter. So in terms of who's at risk of developing preeclampsia, so this is a table from the SOGC guideline depicting the risk factors. And I just want to state that this is not an exhaustive list at all. And we do have a lot of other, risk factors that we consider, including autoimmune conditions or family history, like a first-degree relative with a history of hypertensive disorder in their pregnancy. But this is this is definitely a list to be aware of. So In terms of the high risk category, so if you have one high risk factor, that means that, we would definitely be starting you on aspirin for preeclampsia risk reduction. If you have two or more moderate risk factors, then that's also a consideration that we will start you on aspirin to reduce this risk. So for the high risk factors, the guideline says prior preeclampsia, but really we should be saying prior hypertensive disorder of pregnancy. So including anything like gestational hypertension, HELP, or preeclampsia. For demographics, an elevated BMI, so a pre-pregnancy BMI greater than 30. This is probably a population that we miss more often. And then pre-existing medical conditions such as chronic hypertension, diabetes, chronic kidney disease, lupus, and antiphospholipid syndrome. Again, we consider other autoimmune conditions such as IBD and systemic sclerosis in this category as well. And then the current pregnancy, so was IVF utilized, for example, and that risk actually increases with donor egg or sperm. And then our moderate risk factors, just wanted to highlight that the maternal age cutoff in the guidelines is 40. However, we generally apply 35 at our institution, as well as things like nulliparity, multiple gestation pregnancy, or if there's been prior fetal outcomes of placental insufficiency, such as stillbirth or fetal growth restriction. So our ability to predict and say who is at high risk is improving. So in addition to all of those risk factors that we just reviewed, there are also markers through ultrasound findings as well as serum biomarkers that are allowing us to predict this better and better to understand who needs preeclampsia risk reduction with aspirin and who needs to be monitored or surveyed more frequently. So this is the risk calculator from the Fetal Medicine Foundation, including the risk factors we chatted about, but also includes things like the uterine artery pulsatility index. This is something that's found on an ultrasound within the first trimester, and it's looking at uteroplacental perfusion. And if it's high, it implies that there's impaired placentation and that you're at risk of developing preeclampsia, fetal growth restriction, abruption, and stillbirth. And then we've got serum biomarkers such as PAPA, as well as the placental growth factor, which again, the PAPA is part of first trimester screening. But if these levels are low, will indicate that you're at higher risk of fetal growth restriction, preeclampsia, preterm birth, and stillbirth. And those would be indications as to why we would also initiate aspirin and increase someone's surveillance through pregnancy. This is a table from the SOGC guideline that, again, the main purpose is to demonstrate that multi-system involvement. So we're going to go through more of the severe features of a lot of these different organ systems in the upcoming slides. But I just wanted to highlight that, again, you can see that it's starting from the central nervous system, cardiorespiratory, hematologic, renal, and hepatic. And then on the left-hand side, there's at the top, you can see that it says follow closely, whereas on the right-hand side, it says deliver regardless of gestational age. So we used to use more terminology around severe preeclampsia or preeclampsia with severe features, and that was sort of modified in this more recent guideline, although clinically we will still say that. Something, some signs and symptoms that you might be more familiar with would be on the follow closely side, where individuals with preeclampsia present with high blood pressure, headache. They might have some changes within their platelet count and liver enzymes and maybe some right upper quadrant pain. But then the deliver, regardless of gestational age column, is really the severe features of those organ systems. Which we'll be talking about. So just in brief, from a maternal perspective, from the central nervous system, things like eclampsia, our posterior reversible encephalopathy syndrome, cortical blindness or retinal detachment, a decreased LOC, stroke, mostly hemorrhagic, or TIAs. From a cardiorespiratory perspective, severe hypertension, decreased oxygen saturation or pulmonary edema or requiring inotropic support. Hematological would be just the degree of thrombocytopenia or if you require transfusions. Renal, an acute kidney injury, or having an indication for dialysis. And then hepatic severe features, for example, of HELLP syndrome would be where you develop a hematoma or a rupture. And we'll talk through those a little bit more. This next slide is then to also demonstrate the fetal manifestations of preeclampsia. So we have a lot of the maternal end organ dysfunction that we chatted about, but then from a fetal perspective, there's also a lot that can happen in terms of the uteroplacental insufficiency or ischemia. So that might come down to having abnormal non-stress tests, decreased amniotic fluid volume, abnormal Dopplers, or this angiogenic imbalance, which we're going to talk about a little bit later on. And then on the more severe side, where you're delivering, would be abruption with maternal or fetal compromise or intrauterine fetal demise. So first, focusing on the central nervous system. So in terms of eclampsia, so this did happen within this case, the incidence, there's a big range from about 1.6 to 10 per 10,000 deliveries. And that range is probably the difference, between, different lower resource settings where access to care and appropriate management protocols and surveillance protocols are different. The pathophysiology of this is not completely well understood, but probably multifactorial in terms of having a disruption of the blood-brain barrier. So increased permeability, endothelial dysfunction, which is the mainstay of preeclampsia, and then this autoregulation failure in acute hypertension. So the lack of the ability of the brain to sort of keep flow constant despite what's happening in terms of the systemic blood pressure, where it can protect it from over or under perfusion, and cerebral vasospasm. And then they've looked at autopsies of individuals with eclampsia, and that sort of confirms that there's evidence of the cerebral edema, white matter hemorrhaging, hemorrhages, as well as necrosis. In general, management, because this is a severe feature, includes magnesium sulfate, where you're loaded and then started on an infusion, emergency delivery, which we saw in our case, as well as treatment of severe hypertension. The other, deliver regardless of gestational age, neurological complications include hemorrhagic stroke or intracerebral hemorrhage, as well as PRES. Again, similar pathophysiology to what we were talking about within eclampsia in terms of the blood-brain barrier permeability and that cerebral autoregulation that is sort of failing in this context, as well as things like hypercoagulability and inflammatory state. So in our case, this is a CT scan of the patient where there was evidence of a subarachnoid hemorrhage in the right frontal lobe. And then the CT also commented on regions of white matter hypodensity in the bilateral centrum, semiovale, parietal, and occipital lobe, suggestive of PRES. And so about 98% of individuals with eclampsia have radiological evidence of PRES. Similar in terms of management around delivery and blood pressure control. So we know that, in terms of these cutoffs that we utilize in pregnancy, and that 160/110 in pregnancy, that is a higher risk for intracerebral hemorrhage. So our goal is to get under that target and ultimately less than 140/90 through the use of short-acting agents. And then also for these particular, especially ICH, would be identifying and correcting any coagulopathy that has been identified. Moving on to the cardiorespiratory system, one of the more common things that we can see would be pulmonary edema, as well as LV diastolic dysfunction. And the pathophysiology behind this in preeclampsia is thought to be due to increased systemic vascular resistance and then capillary leak leading to edema and pulmonary edema. And in terms of the LV diastolic dysfunction, likely from abnormal LV remodeling and hypertrophy. So in our case, this is a chest X-ray from the case where there was evidence of bilateral pleural effusions more on the right than the left with interstitial edema. They went on to get an echocardiogram, which demonstrated a normal EF of 62% and normal wall motion, but couldn't comment on the diastolic function. From a renal perspective, again, this endothelial dysfunction happens at the level of the kidneys as well, at the glomerulus. So you can have changes in expression of podocytes and also possibly loss and injury of them. And that can lead to significant proteinuria, impaired glomerular filtration, and in very severe cases, renal failure requiring dialysis. So in our case, again, the application of this was that there was development of an acute kidney injury with a creatinine peaking around 226 and nephrotic range proteinuria. For these individuals, changes within we might not see actually resolution in terms of their renal dysfunction until months postpartum, particularly that proteinuria or their creatinine sort of returning to baseline. And then from a hepatic as well as hematological perspective, the more severe presentation within preeclampsia is HELLP syndrome, which is defined by hemolysis, elevated liver enzymes, and low platelets or thrombocytopenia. These individuals present with headache, nausea, vomiting, right upper quadrant pain, hypertension, and edema. But it is really important to note that about 10 to 20% of cases of HELLP syndrome are not associated with hypertension. In terms of the pathophysiology, this is something that we're actually actively learning more about. So alongside the endothelial dysfunction and the pro-inflammatory state and vasoconstrictive state that we referred to, there is more information talking about increased activity of the alternative pathway of complement and how HELLP syndrome has similarities to atypical HUS as well as PNH in terms of the laboratory abnormalities that you're seeing. So there are studies that are looking at this, the APC. We know that there are germline variants that regulate complement that have been found in women with HELLP syndrome and complement activity in these pregnancies as well. And so there are, there's a case report as well as a case series that actually is that have looked at the use of eculizumab in the context of premature or preterm severe HELLP syndrome in order to potentially prolong pregnancy. One of the studies, was able to prolong pregnancy by about 17 days, whereas the case series, there wasn't as much of a time that was gained. But at that gestational age, similar to our case at 24 weeks, for example, hours and days truly make a difference for fetal outcomes. So this is something that's actively being researched. So in terms of each of those severe manifestations, a big part of that is also the hypertension management that I just wanted to highlight briefly. So our first, go-to agents in the context of hypertension in pregnancy are labetalol and nifedipine XL. And I just want to note that there's two versions of nifedipine, so the XL and IR version for both more long-acting and short-acting. And this slide just demonstrates, the sort of starting doses and maximum doses that we consider in pregnancy. The other agents that we will utilize include methyl-dopa, although we try to avoid this postpartum just because of the risk of maternal depression. And we utilize hydralazine often as our third agent if required. Now, we are, as I talked about, we are seeing individuals enter pregnancy with chronic hypertension who are already on multiple agents pre-pregnancy. And so we often or can sometimes exceed what we actually see on this slide. So other agents that we consider adding are alpha blockers, nitro patch, and diuretics, dependent on the clinical presentation and context. In terms of ACEs and ARBs, we don't use those in pregnancy, but if an individual has been on an ACE or ARB pre-pregnancy for CKD or significant proteinuria, then we will continue them until pregnancy is confirmed because of the benefit of that medication. And then ACE inhibitors can be reintroduced in the postpartum period, even while breastfeeding. In terms of our hypertension goals and targets in pregnancy. This is also something that is something that we're looking more into, but it has been informed by two trials, the CHIPS trial and well as the CHAP trial. Now, again, we don't have as much evidence for what to do in severe preeclampsia or severe hypertension. These trials are mainly looking at individuals with chronic hypertension. So for the CHIPS trial, they were looking at and included individuals with pre-existing or gestational hypertension. They were looking at either tight control with a diastolic blood pressure of less than 85 or less tight with a diastolic blood pressure of 100. And they had a composite primary outcome, which included pregnancy loss or high-level neonatal care. And a secondary outcome was serious maternal complications. So what they found was that the less tight control, so if you were targeting a diastolic of 100, it was associated with a higher frequency of severe maternal hypertension. And then we acknowledge that that is associated with poor outcomes, specifically increases our risk of things like ICH. So the target diastolic blood pressure became less than 85. And then the CHAP trial in 2022 sort of confirmed the things that we were doing already. This included patients with mild chronic hypertension to either target a blood pressure less than 140/90 or less than 160/105. And it was a composite primary outcome, including preeclampsia with severe features, medically indicated preterm birth, placental abruption, or fetal or neonatal death. And what that found was that if we target a lower blood pressure, then we have got better pregnancy outcomes, and it's at no increased risk in terms of small for gestational age birth weight. So this was something that we were already doing in practice, but now have a trial that's sort of that's confirming that there are better outcomes if we were to target a lower blood pressure. And then our severe hypertension management varies a bit because we want to focus on short-acting agents because of those neurological complications. So again, severe hypertension is defined as either systolic greater than or equal to 160 or a diastolic greater than or equal to 110. So our agents are similar, but different formulations. Nifedipine IR is a great first-line option. So it's 5 or 10 milligrams that an individual will chew. It's accessible on the ward and might buy you some time to get the individual to a more monitored setting in order to be able to start administering either IV labetalol or hydralazine in order to treat the severe hypertension. In terms of other management options for severe hypertension, magnesium sulfate is often also part of this protocol. So if there's severe hypertension or adverse maternal conditions, so thinking back to that chart where we say deliver regardless of gestational age, that are at high risk of developing eclampsia, so those severe features. And this was really informed by the MAGPIE trial back in the early 2000s, which showed that magnesium lowers the risk of eclampsia and reduces maternal mortality. There's been other studies that have then come out to show that it's superior compared to other anti-epileptics and or placebo. And the physiology behind how this works is largely due to lowering peripheral and cerebral vascular resistance, relieving vasospasm, and decreasing arterial blood pressure. So there is a loading dose, which is 4 grams, and that's infused over 20 minutes, followed by an infusion. And it's typically continued for about 24 hours following delivery and requires monitoring for signs or symptoms of toxicity, usually with a Foley insertion and in a step down or ICU environment. So in terms of our case, the case itself really highlights that many different services and teams were involved, including obstetrics, ICU, anesthesia, NICU, obstetric medicine, hematology, neurosurgery, nursing, spiritual health, and social work. And that's one of the main takeaways from the presentation is, again, identifying the diverse presentation, but then the importance of having this interdisciplinary and collaborative approach to these patients because of the multi-system involvement. Unfortunately, this did result in neonatal demise following resuscitative efforts in the OR, and that was largely, probably in the context of early gestational age and the intrauterine growth restriction that was identified. The individual was admitted to the ICU and continued on magnesium sulfate for 48 hours and extubated on post-operative day 1. and was then discharged home on a combination of both labetalol as well as Adalat at pretty high doses at that time. They've been seen in follow-up and were able to wean off antihypertensive therapy within a month postpartum, as well as there was evidence of normalization of that end organ involvement by about 3 weeks postpartum. But the care of these patients does not end following delivery. There's a lot that happens in the postpartum period, which needs to be highlighted and also shared between specialties. So following delivery, we often can actually see a little bit of a decrease in individuals' blood pressure. And that's probably a combination of maybe sometimes blood loss during delivery, anesthetic agents, but also the initiation of magnesium sulfate. However, as we talked about at the beginning, there is then that rise that we appreciate in that postpartum day 3 to 6. So often these individuals are staying in hospital at least until postpartum day 3, sometimes longer if we're still titrating medications at that time. What might be a little bit different in what we're changing in terms of our practice is what we're targeting in terms of our blood pressure postpartum. So historically, we would say less than 140/90, but we are now shifting to more of less than 130/80. And we'll talk about some of the data behind that to help reduce readmission rates. And that also aligns a little bit better with our new hypertension guidelines. And we know that there's better outcomes in the long term. In terms of the medications that we utilize, so if an individual is breastfeeding, for example, so we are still, our first lines are labetalol and Adalat XL. Sometimes they're discharged home on hydralazine, but again, we can introduce ACE inhibitors, and the majority of data is largely on captopril, quinapril, and enalapril. However, we're very comfortable introducing ramipril as well, and this just allows for a nice once daily dosing compared to a lot of the other agents that are anywhere between 2 to 4 times a day. So the first few weeks is a lot around that blood pressure management and targets. And then this is where our postpartum vascular clinics come in, where we are following individuals for about 1 year postpartum, up to 3 visits at sort of 3, 6, and 12 months. And I'll sort of walk through what our care is of those individuals. So in terms of that first visit at 3 months, part of it is going to be, blood pressure, ensuring resolution of end organ involvement, although it might not be completely back to normal at that time, as we talk specifically about that renal component. But this visit is often, or can be, really for emotional support and counseling. This, having the diagnosis of preeclampsia, depending on the outcomes or just how quickly things changed, the unexpected nature of it, wondering why it happened, not being able to process things at the time. There's a lot of just information sharing and counseling and support that's provided at that first meeting, to provide space once an individual has been able to think about it and process and ask questions. So that is a big component of our job too within this postpartum vascular clinic. And then other things early on that we generally do try to discuss too would be around contraception and interpregnancy intervals. Again, sometimes a hard topic to bring up for individuals about what comes next, but we know that individuals are at higher risk of adverse pregnancy outcomes if pregnancy intervals are really short or if they're very long. And there's more data coming out around that. So we do want to make sure that we are talking about contraception. In terms of further along in the postpartum vascular clinic, we are screening for secondary causes of hypertension. And I just want to highlight the new primary hyperaldosteronism guidelines that came out earlier last year, which really are suggesting that all individuals with hypertension should be screened and should undergo the aldosterone-renin ratio. This is definitely a patient population that we recognize are underdiagnosed in terms of primary hyperaldosteronism. So this is something that we are trying to screen more for, even in the context of at that point, if we're not sure if they necessarily have chronic hypertension, but screening for it and thinking about it. We're counseling on lifestyle modifications, in particular, activity levels as well as dietary changes, and then screening for cardiovascular risk factors. So in terms of the guidelines for our dyslipidemia or diabetic guidelines, we often don't maybe start screening for these unless there's high risk features in individuals or at a later age. But this is a specific patient population where we are doing that screening at an earlier age because of preeclampsia or hypertensive disorder being a risk factor. And then as we move forward, and these things are sort of discussed all throughout the visits, but we're counseling on recurrence in future pregnancies. We're discussing their 2 to 4 times increased risk of cardiovascular disease and discussing optimization for pre-pregnancy. The next couple of slides are just to demonstrate recurrence risk. So in terms of the main takeaway from this is just to say that it's been well studied. We know that if you do have a hypertensive disorder of pregnancy, that you are at higher risk. If it happens earlier on in a pregnancy, it has a more severe phenotype, your risk is increased. And that was really what was showed by this prospective cohort study. So it is associated with the subtype and how early it happens and how severe it is. This was an older study that also showed the same thing. So on the left-hand side, it's looking at recurrence percentage in the blue chart along the y-axis, and then the x-axis is sort of what type of hypertensive disorder you had. So you can just see that, if you had any type, your recurrence of any type of hypertensive disorder would be about 20% in the next pregnancy, but then splits it up based on the different subtypes. And then the right-hand side in orange, again, just shows the earlier this happens in a pregnancy, increases your risk for subsequent pregnancies. So what can we do? What can we do to prevent preeclampsia or help reduce the risk? So we talked a lot about identifying risk factors and utilizing that risk calculator. And then the educational piece is sort of the next step. So for preeclampsia prevention, individuals with at least 1 high risk factor or 2 moderate, we do start aspirin 162 milligrams nightly. And the guidelines say before 16 weeks, but we're generally doing that around 10 to 12 weeks after an ultrasound has demonstrated, a viable intrauterine pregnancy. And this was informed by the ASPRI trial in 2017. There are dosing variations between institutions. At McMaster, we utilize 162, and there is some belief that the 81 milligrams might be less effective based on platelet insensitivity that can be seen in about 40% of patients. We ensure adequate calcium intake. So if between a prenatal vitamin and dietary intake would be less than 900 milligrams a day, then we will recommend being on some calcium supplements. We recommend 140 minutes of moderate intensity exercise per week, as well as often these individuals who have had a hypertensive disorder previously will have more of a timed delivery, potentially in a subsequent pregnancy, depending on how that pregnancy is going. So the numbers down at below are sort of some estimates around potential risk reduction with utilizing each of these different preventative methods. So aspirin up to 60% risk reduction for preeclampsia. And really that's about how it's impacting that trophoblast invasion and placental sort of development early on in that first trimester. The last thing that I just wanted to highlight would be around future directions. So where are we headed and what are we learning more about? So the first one is around the S-FLT and placental growth factor for risk stratification. So this is a ratio, these angiogenic factors that we identified that are in imbalance. And there have been multiple validation studies that have looked at sort of the predictive values of looking at this ratio. And I just want to highlight first and foremost that the negative predictive value The ratio of less than or equal to 38 is over 99%. And this is a ratio that is being introduced in order for us to rule out the development of preeclampsia within the short term. So these, again, are produced at the level of the placenta and are biomarkers, and we're looking at ratios to identify if someone's at risk in terms of preeclampsia. So this has recently been introduced in Hamilton and championed by Dr. Serena Gundy. This is an ongoing quality improvement study here. It is a test that's available to obstetrics between 20 and 36 and 6 weeks gestation. And again, clarifying diagnosis if it's an atypical presentation or helping to inform management. So does this patient need to be admitted, or can they be safely discharged? Or do they need intensified surveillance and or intervention? And it's an adjunct to our clinical judgment. So in terms of the interpretation, again, if this ratio is less than or equal to 38, you are considered low risk in terms of the development of preeclampsia in the short term. Whereas you can see if it's greater than 85, if you're less than 34 weeks gestation, or greater than 110, if you're greater than or equal to 34 weeks, then you're high risk category. And these are individuals that are generally admitted, undergo fetal monitoring, and have more surveillance and potentially intervention occurring within the short term. This is just a sort of infographic that you might see either at McMaster or St. Joe's depicting that. The other area is really preeclampsia subtypes. I think, something that I hope you appreciate through this presentation is just the spectrum of disease here with preeclampsia. So we have a diverse presentation outcomes, a range of risk factors. And so we see differences in terms of timing, whether or not it happens in pregnancy or postpartum, what end organs are involved, whether or not it's predominant maternal or fetal manifestations, the severity of the phenotype, and then what we see later in terms of placental pathology. So this is an opportunity to develop subtypes where we then can target more in terms of like prevention, prediction and treatment, and more personalized care within preeclampsia. Another area is sort of the impact of the hypertension guidelines. And so how we define hypertension has been modified, and when we initiate pharmacotherapy has also been modified. And this is sort of to say, how does this impact our blood pressure targets during pregnancy and or postpartum? When obviously, the guideline is potentially looking at a different patient population and more in primary care, but does this inform our care within pregnancy as well? In generally, we do use some lower targets for specific patient populations, for example, chronic kidney disease, diabetes, or chronic hypertension. And then I did highlight as well postpartum that we are targeting less than 130/80. This is based on a few studies that have showed that if we are helping modify or titrate antihypertensives, that individuals generally will have a lower blood pressure through the POP-HT RCT in 2023. And then another that came out in 2025 that showed that tighter blood pressure control is associated with reduced postpartum ED visits, specifically within that first week where we can see the rise in blood pressure. So does this, there's definitely more cohort studies and trials that are ongoing for tighter blood pressure control within the postpartum period. And this is an opportunity similar to our peri-op population for virtual monitoring postpartum and or use of AI tools to help improve care for the patient population. And then lastly, really informing our postpartum care and long-term care of these patients. We know that they are at 2 to 4 times increased risk of premature cardiovascular disease, including heart disease, stroke, hypertension, diabetes, CKD. The hypotheses behind this would be, are we unmasking those who are predisposed, or are the hypertensive disorders of pregnancies causing vascular dysfunction and or worsening of these pre-existing subclinical risk factors, or a combination of both of these? Regardless, this is something that we need to identify as a risk factor for these individuals when we are seeing them either in our specialty care clinics, in the emergency department, and asking about hypertensive disorders of pregnancy as a risk factor and how they are doing in terms of modifying additional risk factors for cardiovascular disease. So I hope that through the talk, you're able to sort of achieve these learning objectives. These are my references. I just want to say thank you. If you have any questions, I'm happy to also answer them via email. Thank you to Dr. Serena Gundy for sort of reviewing the slides and providing feedback, and then the obstetric medicine group here for supporting me throughout my career so far.
Perfect. Thank you very much, Katherine. That was an excellent overview of preeclampsia and its complexities, along with an emphasis on the importance of a multidisciplinary approach. At this point, I'd like to open up to questions, either putting them in the chat, or if you want to raise your hand, I could unmute you. So I'll start off with Anne. See if oh, for some reason,
there we go.
There we go.
No, it's okay. Thanks, Jason. That was excellent, Katherine. Really good review. I just have two, potentially peripheral questions, but one is quite germane. I'm just doing some work now on the details of cardiovascular risk assessment for people largely around, we probably should be using statins earlier in primary prevention, but it struck me there are a whole bunch of factors that we don't include in, for example, the traditional Framingham risk reduction, which was developed, of course, mainly on men. But I wondered if you had any thoughts or evidence around the importance of pregnancy-related hypertension and complications like eclampsia on overall cardiovascular risk reduction, such that should it be a factor in our assessment. And my second question is just, what thoughts do people have about the very overweight mom and the use of Ozempic or, the GLPs in pregnancy?
Great, thank you. So in terms of the first question, personally, I do think that, preeclampsia or hypertensive disorders of pregnancy should be recognized as a risk factor and integrated into our guidelines. And because right now we don't exactly have clear guidance on where they fit into things like that Framingham risk score or the blood pressure targets in terms of that high cardiovascular risk category, as it's not listed. So I think there's a lot of opportunity to recognize this as a risk factor. In terms of statin therapy, we do, in some, because we are screening for it at a younger age and are identifying individuals that do have dyslipidemia, sometimes we are sending them to the lipid clinic or initiating a statin therapy postpartum if there's persistent dyslipidemia and other risk factors, because they are not just in that low risk category in our minds. But we also have to consider is the individual breastfeeding, because we don't have, evidence of safety of statins completely in that patient population yet. But also, are they planning future pregnancies, and what's the ultimate and sort of absolute benefit of initiating pharmacotherapy for even a short period of time before preconception or planning for the next pregnancy? So a few things that play into that. And then in terms of Ozempic, currently it is stopped about 2 months prior to pregnancy. So one of the sort of complications around the use of this medication would be, for individuals who respond really well, when they do stop it, we can see potentially some pretty rapid weight gain within that first trimester, depending on how much was initially lost. But I think it is a really important part of what you were referring to and talking about, again, modifying those risk factors and addressing them. So we do, after, postpartum and talking about optimization for a future pregnancy, that does become an option depending on timing. And then there are also clinics that we will sometimes refer individuals to in order to help with elevated BMI and metabolic syndromes, as this is something that they've often, been experiencing for a significant period of their life.
That's great. Thanks, Katherine. Next question is from Dr. Levine.
Okay, thanks. That was great talk. I have just a quick question, or I'm interested in your view. Is why do you think magnesium works better than benzodiazepines in that acute eclamptic seizure?
in terms of like the pathophysiology of the eclamptic seizure, because like, I think it comes down to that pathophysiology of that dysregulation and what's happening at that vasculature level and that, dysfunction. So potentially more so in regards to the it working in terms of that vasodilatory impact, because we know it does also lower blood pressure for these patients when we start them and we give them that load, compared to the sort of benzodiazepines and not having that impact, because you're treating almost sort of the severe hypertension, which is sort of the main risk factor for that dysregulation. Not only with the antihypertensive therapy, but also with the magnesium sulfate and causing that vasodilatory effect is sort of what my thoughts are, but I'd be interested to hear from your pharmacology perspective if you're in agreement with that.
No, I'm kind of curious because we do know that studies have shown that the benzos don't have as a good an outcome as the magnesium in this population. So, you think that the acute crisis of the seizure is really, you want to get that under control. And we know that normally benzos are good for status epilepticus and things like that. So it just surprises me that we've drifted away for that in this population. That's all. Yeah. I think your explanation that maybe we're treating the blood pressure at the same time is the adjunctive benefit.
Mm-hmm.
That's great. Thanks, Mitch. Thanks, Katherine. And we have another question here from Dr. Preeclampsia.
Hello, can you hear me, Jason?
Yep.
Oh, sorry. Yeah. Great talk, Katherine, and beautiful slides. Thank you. I just have a couple of comments. I often get called to see patients with query PA, primary aldosteronism in pregnancy. In fact, they're protected during pregnancy because I don't know if I missed it, but progesterone is actually an antagonist to aldosterone. So they're often protected. We often see a rebound hypertension after if they do have PA. So just a physiological point that I wanted to make, and also clinically important too. With regards to the comment about semaglutide, it's a great drug in patients with PCOS to help them conceive because it induces ovulation because of the significant weight loss and restoration of insulin sensitivity. So yeah, I agree with you. We stop it often. We tell them, look, use contraception, but once you once you've lost a certain amount of weight, or we just guide them, and we do tell them to stop it 2 months in advance. But it's a great drug for inducing ovulation in the setting of PCOS or anovulation. Thank you so much.
Oh, thank you.
Any other questions at all? I just had one question as well, Katherine. And obviously in the internal medicine world, we often see a degree of white coat hypertension in the clinic setting, different age group, different demographic, of course. But how often does that come up as a question, or do we ever use 24-hour ambulatory monitoring to confirm or refute the diagnosis?
Yeah, no, great. Thank you. So it does come up, but with this patient population, they're very, tend to be quite involved in their care. And so their home monitoring is really good. So it comes up when we see a discrepancy really between what someone's measuring at home and then what we're getting in office, and then trying to tie in the clinical picture to that too. But if someone reliably, we've calibrated their blood pressure machine, they've brought it in, we've gotten similar measurements, and then at home, all their measurements are excellent, like we do rely on those home measurements for sure. But if we're seeing overall general trends, then that will make us sort of reconsider it. But we do definitely see, different things impacting that white coat hypertension in the population, such as anxiety, driving blood pressures up in office, and having to rely on those home measurements. For the ambulatory blood pressure monitor, I tend to not necessarily measure it in the context of pregnancy, just because they're doing those home measurements so frequently. But I do use it often from time to time postpartum to sort of see, especially if we're trying to wean off certain medications or we're getting those discrepant results again, to understand how well controlled they are if we're kind of getting borderline readings. That's sort of a period of time when I might do the 24-hour. just because as well in pregnancy, we have such a limited amount of time to get that test done and then to get the results, that the impact that it will have on your care has sort of already passed by the time it's back.
That's great. Thanks, Catherine. Doesn't look like there are any other outstanding questions in the chat or any other hands up. So with that, I will end the rounds for today. Just a reminder, everyone, for next week, on February 5th, I believe, Grants Rounds will be hosted through Hamilton Health Sciences. Dr. Anna Chevchovich will be presenting on substance use and infectious disease. So thank you very much, everyone, for joining us for another Grand Round session.
Thank you.